Hello, I'm Nadira Jayasekara, one of the specialty doctors work in Swindon Hospital Hematology. I'm going to talk to you today about allogenic bone marrow transplant, why we do it and how we do it. Outline of my presentation, I'm going to talk to you about how the allogenic bone marrow transplant differ from autologous bone marrow transplant, what you usually do day to day in the board, and what are the indications for allogenic transplant, essential requirements in an allograft center, and I'm going to talk to you about stem cell donor and the HLA match, and patient preparation for allograft, adverse effects of allogenic transplant, and how to manage the patient after transplant, and role of peripheral hospital hematology team in managing patients like this. The allogenic transplant process, where there is a donor and donor um, donate stem cells. These stem cells are processed and sometimes cryopreserved, and then patient have conditioning chemotherapy or chemotherapy plus some radiotherapy. We call it total body radiation, and then patient will have the stem cell infusion. Similarities to autograft. Patient will have conditioning chemotherapy in both these transplant processes, and both condition patient need involved hospital care, and side effects such as mucositis and severe infection can happen in this immunosuppressive treatment modalities. Close monitoring is indicated. Patient blood and blood products has to be irradiated, and even after the transplant, patient will have a post-transplant clinic monitoring. Let's talk about differences to autograft. Um, in this allograft setting, patient gets stem cells from a donor, not from himself, and procedure is very complicated, long hospital stay, continuation of immunosuppressive medication for few months post-transplant, which doesn't happen in autograft setting, and high risk of complications such as graft versus host disease, CMV reactivation, severe sepsis, veno-occlusive disease, and the transplant-related mortality is high in autologous bone marrow transplant, and autologous patients need long-term follow-up. Let's move on to indications for allogenic bone marrow transplant. As you all day to day see, AML patients with high and or intermediate risk cytogenetics, um, we send them for allogenic bone marrow transplant. Aplastic anemia patients, especially young aplastic anemias, sent for allogenic bone marrow transplant. ALL patients, T-cell lymphomas, high or intermediate risk myelodysplastic syndrome MDS, relapse refractory B-cell non-Hodgkin lymphoma after several lines of treatment, relapse or refractory Hodgkin lymphoma, congenital anemia such as thalassemia, or sickle cell anemia. Some congenital immunodeficiency syndromes are also indicated allogenic bone marrow transplant. Why can't we do allogenic transplant in Swindon? So let's talk about requirement of a transplant unit. It has to be inpatient unit with single bed and with isolation facility, and should have ancillary medical services, ITU, GI and pulmonary service, emergency room, an outpatient clinic with single patient examination rooms, blood bank 24-hour on-site service with ABO typing, cross-match, RBC and platelet for infusion, irradiation and leukocyte depleted products, and laboratory service which can do full blood count, chemistry, serology for viral screening, basic bacterial and fungal culture, CMV, PCR or antigenemia, access to cyclosporine, tacrolimus or sirolimus levels, HLA typing lab, accredited HLA typing lab needs to be there, stem cell collection facilities, peripheral blood stem cell apheresis capability, bone marrow harvesting facility, and expertise for matched sibling donor, stem cell processing facility, CD34 enumeration, refrigerator for blood and bone marrow, control cryopreservation capability of autologous stem cell products, equipment and expertise to process ABO mismatched cellular products, radiology support, routine X-ray, ultrasound, CT, placement of central venous catheter, pharmacy support, availability of conditioning chemotherapy, antimicrobial agents, immunosuppressive medication to treat or prevent graft versus host disease. So the last bit of requirement of a transplant, you need human resources, appropriately trained medical, nursing, laboratory, pharmacy, and multidisciplinary medical staff, radiology, pathology, ICU, surgery, gastroenterology, pulmonary, neurology, and ophthalmology, an outcome database, data reporting management, and quality management, written institutional protocols such as NSHA, BMT protocols, regular audits, system to detect errors or adverse events for corrective and preventive actions. I got this information from EBMT latest handbook. Before talking about donors, we need to know what is HLA matching. HLA is called human leukocyte antigens. Mainly we look at HLA A, B, C, HLA D, R, D, Q, and DP. So any one of you have two loci of each HLA, and these are genetically acquired. This slide shows you the inheritance of HLA genes from mother and father. Among the siblings, there is a 25% chance to get 100% HLA match sibling. Let's talk about patient preparation for allograft. If the patient has a potential indication for allograft, at the beginning we'll do blood grouping, CME serology, and HLA typing. Usually we do it in the peripheral hospital at the place where we made the diagnosis, and then we refer this patient to myeloid MDT or any relevant MDTs, such as lymphoma MDT in the cases of relapsed refractory lymphoma, and then they decide whether this patient is allograft candidate or not, and decide to refer to allograft center, and referrals being made. First visit to pre-transplant clinic is arranged, and it is a first 1 hour meeting face to face. At that meeting, transplant consultants talk to patient, decide the transplant related mortality risk, and talk about potential sibling donors and their medical condition if the patient knows about it, and whether they are happy to contact for HLA typing. And at the same time, usually started a unrelated donor search from the registries. During this patient preparation period, patient will have chemotherapy or bridging therapy as per the plan by myeloid MBT team while donor search is carried out. And this has been already referred to BMT team, bone marrow transplant team. So there is a MDT going there. So they discuss the case to finalize the donor and conditioning chemotherapy. Then patient needs organ assessment such as echo, lung function, ECG. Those things will be arranged in a peripheral hospital or in the main tertiary care center. And disease remission status assessment such as bone marrow or PET-CT. And further, patient assessment for fitness, which is called HCT-CI score, hematopoietic stem cell transplant comorbidity index. It is called SORA score as well. You can find it like as online calculator from QXMD, or there is a written one in NSSG BMT site, and then they schedule a transplant date. In BMT, MDT, and scheduling meetings, the decision is made about the best donor for particular patient, the time frame, and conditioning protocols such as reduced intensity conditioning, MUD, or myeloablative, and eligibility to trials. This slide shows summary of donor selection criteria. So the priority goes to HLA matching 10 out of 10 mainly, if not 9 out of 10, and donor age, younger donors are preferable. CMV matching is important, and the donor registry should be a reliable one. Ideally, male donors are selected over female donors. HLA-DPB1 match is important, and ABO matching is also important. How you prepare donor for bone marrow transplant? Donors can be family members such as full or haplomatch, siblings or children, and unrelated donors from donor registries. In both the situations, they should have a medical assessment 1 month prior to planned day of transplant, and then they will be cleared for donation if there's no significant medical problem or if there's no transfusion transmitted infection risk. This donor assessment is carried out by an independent team not responsible for the recipient. Donor stem cell collection, usually we use fresh cells. So the stem cell collection happen in apheresis center a day prior to stem cell infusion. In some conditions, such as in the era of COVID, cryopreserved cells are used, and that in that case, collection happens before transplant conditioning started for the patient. Adverse effects of allogenic bone marrow transplant. It can give rise to severe life-threatening infections following significant immunosuppression. Acute and chronic graft versus host disease is a devastating adverse effect from allogenic transplant. CMV reactivation can happen, and which can give rise to severe diarrhea and severe chest infections. Veno-occlusive disease is another side effect. Severe mucositis, nausea, diarrhea, those are usually chemotherapy conditioning related side effects. And there can be engraftment syndrome when the graft is taken up by the patient's body. There can be fever and some flu-like symptoms, and the graft failure, where the graft is not working and patient's blood counts are not improving. This condition is called graft failure. In some cases, patient might need a repeat CD34 cell infusion or significant reduction of immunosuppression to let the graft to work. It's a difficult situation to manage, and rarely there can be disease relapse even just after the transplant. And rare transplant related side effects are microangiopathic hemolytic anemia such as thrombotic thrombocytopenic purpura, or in some cases autoimmune hemolytic anemias can happen. This slide is about graft versus host disease, which is a major cause of non-relapse mortality in bone marrow transplant. The graft versus host disease can be acute or chronic. Usually we call it acute before the day 100, but there can be chronic overlap graft versus host disease starting even before day 100. And usually in acute graft versus host disease, patient will get significant skin rashes and gut symptoms like diarrhea, severe abdominal pain, nausea, vomiting, and liver involvement with cholestatic hyperbilirubinemia. In chronic GVHD, multi-organ can be affected, and there can be autoimmune and fibrotic changes in lungs, eye, joints, mouth, and any organ of the body. Let's go back to patient preparation for transplant. When it is close to transplant, patient will have a blood test and ECGs to check liver, renal, thyroid, cardiac functions, to check CMV status, ferritin level, etc. and reassess HCT-CI score, and patient will have a bone marrow assessment to confirm the remission status, and then patient will have another face-to-face appointment to carefully consider transplant-related mortality and morbidity conditions and the risk, and to sign for the transplant. Then admission is arranged. Chemotherapy is being prescribed on area for conditioning, and the blood bank will be notified about irradiated blood product requirement. And patient might need psychological support. Initial chemotherapy can be given in ambulatory care unit, but the cell infusion is happen as an inboard patient. Allograft admission, patient needs an isolated room and day 0 stem cell infusion. Patient will have prophylaxis for CMV reactivation such as letermovir and acyclovir. Patient will get prophylactic treatment for vein-occlusive disease, the drug called ursodeoxycholic acid, anti-sickness medication as per the protocol, and there can be extra as required anti-sickness. Acute graft versus host disease preventing immunosuppression as per protocol, such as cyclosporine, post-transplant cyclophosphamide, sirolimus, mycophenolate mofetil, or even ATG or CAMPAT. During initial post-transplant management, approximately 4 to 5 weeks hospital stay, blood counts are monitored very closely, and side effects are monitored such as nausea, mucositis, infections, and liver impairment. Patient will have continuous psychological support. Dietitian will assess the patient and prescribe protein shakes and manage the eating, and blood and platelet support, and manage other complications during the hospital stay, initial post-transplant period. After discharge, patient will have blood and blood product support in ambulatory care or day therapy, and weekly bone marrow transplant clinic reviews by consultant. During that period, closely patient is monitored to find out adverse effects such as infection and graft versus host disease. Patient will have chimerism monitoring, disease remission assessment done, periodic bone marrows, PET-CT, assessment by dietitian time to time, and The drug levels are regularly assessed, such as cyclosporin levels, sirolimus, and tacrolimus, and wean immunosuppression as per the protocol. Long-term follow-up of transplant patients. Chronic graft-versus-host disease can appear after several months or even years. Therefore, we will continue monitoring these patients in transplant clinic, obviously not weekly. This can be like every 2 weeks, every 1 month, every couple of months, depending on the patient's situation. Patients have easy access to bone marrow transplant team via CNS nursing team if they develop any complication. How do we fit in managing allogenic bone marrow transplant patient? Usually main contacts in Great Western Hospital is transplant ACP Nikki Knightley. When the patients preparing for transplant, they will need echo, lung function, or bone marrow assessments, and sometimes the Oxford transplant team contact Nikki and ask her to arrange these testing locally. So she will arrange them, and since the decision to do transplant, patient can be admitted to Swindon Hospital with infection, sepsis, VTE before transplant or post-transplant period. Some patients are enrolled in clinical trials and they might need to inform trial team for serious adverse effect recording. Usually Nikki does that too. Initial post-transplant period, patient will need lots of electrolyte replacement such as magnesium, potassium infusions. So it was a long drive to Oxford, so patient will have those things in Swindon Day Therapy Unit. Patient might need blood or platelet transfusions in day therapy unit as well. In later period of transplant, they will have venous sections, regular venous sections for iron overloaded patients in our day therapy center. To have a successful allogenic bone marrow transplant, teamwork is a very important thing. As a local team, transplant CNS, ACP, and hematology consultant plays a part, and the allograft team in Oxford or any other transplant center. There can be pre-transplant specialist nurses and transplant administration team, transplant consultants, blood transfusion service, HLA lab scientists and consultants, donor registries, donor assessment team, psychology support, ACU, ambulatory care unit, heme ward, Macmillan Cancer Support, and Anthony Nolan like organizations also help for the success of allogenic bone marrow transplant. Thank you so much for listening to this presentation. I hope you understand what we do in allogenic bone marrow transplant and why we do allogenic bone marrow transplant. Please add this for your CPD record. Thank you.